Okay, hi everyone. Welcome to this third episode of the REFERROLOGY series. Today we're talking about venous thromboembolism. So we are very fortunate Dr. Yap Eng Soo, who is a hematologist as well as an expert in blood clotting disorders, and also someone who's very actively involved and passionate about education. So we are very privileged to have him here today. So today, Edwin and I will both be asking him a series of questions, and hopefully through this session we'll all have a better understanding of venous thromboembolism. So maybe before we start, right, Dr. Yap, in general, what kind of what guidelines do you normally refer to, or should residents be looking up in terms of VTE related matters?
Well, I think Up to Date has a very good and easy guidelines for you to follow. But for hematologists, we all follow the American College of Chest Physicians guideline, the ACCP guidelines, the latest version of which is in 2016. So that's the guideline.
Yep, thanks. Okay, so maybe we will start with sort of two short case vignettes that we will very loosely tie to the questions along the way. One is more focused on DVT and others a bit more focused on PE, but just framing it around a case may help to just guide the conversation a little bit. So case one is a 50-year-old background DM hypertension who presents with 5 weeks of lower limb swelling with low-grade fever. Went to see a GP thought maybe cellulitis, 5-day course of augmentin, but not getting better. So he came in, on examination-wise, his right calf was noted to be tender on palpation. The pulses were well felt, no very overt surrounding overlying erythema, and I mean the total whites were maybe about 10. So this is the first case that we will guide in terms of DVT. And the second case is that of a 63-year-old background hypertension, hyperlipidemia. Actually was admitted for anterior resection for colonic CA, and the on-call MO was asked to review for shortness of breath and chest pain and some mild hypoxemia. ECG showed sinus tachycardia, the X-ray was clear, and there was some borderline raised troponins. So these are just the two cases. Not much specifics, but hopefully we can have a meaningful discussion about it.
Okay.
Okay, are we going to ask this question?
Yep. So I think one of the frequent questions that might come to a resident's mind when met with such cases is that how certain scoring systems might help in decision making with regards to the next step. And I think we've all heard of scores such as the Wells score, the Geneva score, or the PERC rule. So maybe you could take us through this and when we can actually apply these scores.
So the easy one is Wells. There's a lot of feedback.
Try again.
Is this better?
Yep.
Yeah. Okay, so the Wells score, there is Wells for DVT and Wells for PE. And Wells should be only used in the outpatient setting, meaning that it is not validated for inpatient. Although there are some publications on Wells on inpatient, we usually do not use it. It's well validated only for outpatient patients. So like for the first case, I will use Wells. Geneva and PERC are both used for PE. So you can see that I found that Geneva is a bit more granular, but the problem is a bit more difficult to use the Geneva scoring for outpatient. You shouldn't be using that for inpatient. As long as you suspect the inpatient has PE, you have to scan the patient.
Okay. So I guess a lot of these algorithms have an element of a D-dimer that part in terms of the risk profile of the patient. So perhaps you could just take us through when we should be doing a D-dimer, when we shouldn't, and I guess another question is a lot of our inpatient have other things happening to them like infection, sepsis, but the D-dimer will be raised. So in those instances.
Yes, so for D-dimer, it's only used for patients who are outpatient again. So if you follow the algorithm for outpatient people with Wells, you do a D-dimer. If the D-dimer is negative, you practically rule out by all means and purposes the patient having a DVT or PE. So in inpatient, because as you said, there's many processes that can raise a D-dimer, you do not use the D-dimer, nor do you use any of these scoring system for patients who are admitted in hospital. So if you suspect a inpatient has a DVT or PE, you scan the patient.
Okay. What about outpatients?
Sorry?
Risk. So I guess if it's a high risk outpatient, you need to have a definitive scan. But what patient falls under the intermediate risk profile?
That will go under your well scoring.
Okay, so they will end up getting a D-dimer.
For the well scoring, those with intermittent score, you don't do D-dimer, you scan them immediately because the D-dimer is not discriminatory.
Okay, thank you.
Then with regards to perhaps, maybe this is more pertinent to the second case. If you're suspecting a PE, I think we know that there are various investigations that are available to further confirm or refute the diagnosis. So maybe you can share with us when would be, I think we are mostly aware that CTPA seems to be the gold standard, but maybe you could share with us when we can do things like VQ scans and bedside echoes for RV strain perhaps, and which is the modality of choice in pregnant patients.
Okay, so for scanning, the modality of choice is CTPA. That is without doubt the best. VQ scan has largely fallen out of favor, and even getting a VQ scan in NUHS nowadays is extremely difficult because it's not being done. So CTPA has a sensitivity and specificity of almost 99%. And with all these multi-slicer now, we're having the 64 slicer and 128 slicer. The problem now is not missing diagnosis, but actually over-diagnosis. So like nowadays, we're picking up subsegmental PEs that we may or may not want to treat. So as for pregnancy, the question is whether to do CTPA or VQ scan. That depends on the risk. If you do CTPA because of the lactating breast, a patient who's pregnant, they got breast hypertrophy, you increase the lifetime risk of the pregnant woman getting breast cancer in the future. So actually, you would like to avoid CTPA. You rather do a VQ scan for the woman. The idea here is protecting the mother from breast cancer in the future. So the guidelines actually say when the woman is pregnant, what do you do when you suspect PE? You do an ultrasound DVT. If there's ultrasound DVT is positive, then you don't need to scan her. You just assume that she has a PE because she already has got a DVT. However, if the DVT scan is negative, then you like to proceed on and do a VQ scan. Okay. You don't do a CTPA. Yeah.
Got it. Perhaps for patients that are, let's say, a bit more unstable, or let's say comes into the ED, would you clinch your diagnosis on doing a, let's say, so they have access to, let's say, bedside echo, or let's say ICU patients, and you know like RV strain. In those instances, would you still proceed with a CTPA for confirmation, or in an appropriate clinical context, would that be adequate?
You need some form of proof that there is a clot, because you can imagine you're giving full anticoagulation to a patient. So I would say that if you do a bedside echo, there's RV strain, and for some reason the patient cannot get the CTPA, you can do an ultrasound of the lower limb. If there's a DVT in the lower limb, you assume that that strain is most probably due to a PE.
Yep. Okay. The next question is about investigations for DVT. So I guess it's more pertinent to the first patient. So the first question is general of ultrasound DVT, and I also understand that there's a whole leg and DVT. So when is which done? And do we ever need to repeat if it's negative, let's say?
Yeah. So the sensitivity of ultrasound DVT is very, very high. It's 99% sensitivity and 99% specificity. So the chance of missing is really extremely low. As to whether whole leg versus proximal leg, that would depend. If you send it for, actually you send for ultrasound by the radiologist or by vascular lab, they do the entire leg. They don't just do proximal. So it's usually, if you read in the A&E department, they actually can do proximal, or they do a 2-point ultrasound compression of the leg to diagnose DVT, and that one has surprisingly very high sensitivity and specificity as well. But as far as I know, no radiologists do only proximal leg, they do the entire leg. Okay. Would I repeat ultrasound? Yes, I would. Let's say, for example, a patient inpatient, he has a swollen leg. You do an ultrasound and the ultrasound is negative, but yet the pain is still persistent. You may want to repeat the ultrasound in 1 week's time to see whether you really are missing a DVT. So if you have 2 consecutive ultrasounds that are negative, you can guarantee that the patient really does not have any DVT.
Understand. So if your index of suspicion is very high, clinically looks like a DVT, but first is negative, sometimes you can proceed with a second scan.
Yeah, that's correct.
what are your thoughts on bedside ultrasound and point of care ultrasound? Because I think there are some studies that show that it may, if used in appropriately trained hands, be an alternative. What are your thoughts on this?
I think you need to be trained. I think as long as hospitalist, if the procedurist is very comfortable in doing it, I would say, yeah, go ahead. I fully support this to be done.
Okay.
And I guess the next question would kind of influence your subsequent management, because we've also have terms such as provoked or unprovoked venous thromboembolic events. So maybe you could just share with us and give us a refresher. What are some scenarios that you count as a provoked event?
So of course the common one is surgery. Then the surgery, you put them under major surgery or minor surgery. Major surgery being more than 30 minutes by definition, minor being less than 30 minutes. And of course, whether it's pelvic, abdominal, or thoracic, or wherever the surgery may be. And then of course, it's usually within 1 month of a major or minor surgery. Obesity can be considered, pregnancy, oral contraceptive pills, and then of course, prolonged travel, flight travel more than 7 to 8 hours is considered provoked. Yeah.
What about immobility? So like patients in the wards, oftentimes they're like,
immobility depends whether how immobile you are. If you are completely immobile in bed for more than 3 days, that is considered a major provoking factor. If you have limited mobility about 3 days, then it's considered a minor provoking factor. But immobility is a provoking factor itself. And of course, as you know, patients in ICU, that's of course a high provoking factor.
Yep. Okay, thank you. So maybe this time we won't go into great detail, but perhaps for maybe on-call purposes, if we are seeing a sick patient with a suspicion of PE, yeah, so actually give us an overview of the considerations for massive or submassive PE, and who do we refer to, and what kind of treatment is usually initiated.
Okay, so for massive PE, it's very simple. If you're working in NUH or Ng Teng Fong, refer to the massive PE protocol. There is a protocol in place. You download it from the guides and policies from NUH. And that one will activate a whole bunch of people. It will tell you who to call MICU, call cardiologists, and we will follow the protocol and go down along the line. I think it's easier for you to look at the protocol than for me to say over this video. Yeah, and thrombolysis is usually first line, but for some reason, if cannot, we will also ask a cardiologist. They'll go in and do a percutaneous thrombectomy for you as well.
Okay, thank you.
Okay, the next question would pertain on the treatment and specifics. I guess when do you start? If you have a high index of suspicion, for example, would you start it even before any diagnostic confirmation? For example, if there's some reason that you're getting a delay to your scan, what type of anticoagulation to start, how long to anticoagulate for, and other things like what to use in special groups of patients like oncology patients.
So once again, whether you're inpatient or outpatient, if you're inpatient and you think this patient has a PE, then you should start even while waiting for the scan. So you should start it before the scan is done. Just 1 dose of Plexine will not harm anybody at 1 milligram per kilogram, provided the patient has no renal impairment. If it's outpatient, then let's say, for example, you see a patient in ED, the patient has breathlessness, and you do a well score, the well score is high. You just do a subcu Plexine even before you do the scan. So this is the diagnostic algorithm for it. So there is a role for giving before. Case in point, there was one case many years ago, admitted under RESPI. Patient was diagnosed or had very high suspicion of PE. The patient did not get the Plexine, went down for the CT scan and collapsed and died in the CT scan room with a saddle PE. So I would say don't delay. Okay. Because once you give the anticoagulation, it stabilizes the clot, and that actually will reduce your chance of clot migration or clot formation more. Okay. Duration, very standard. All provoked DVTs and PEs, no matter how big, how small, is 3 months, provided that the provoking factor is resolved when you see him. So at 3 months, you stop. For anything that's unprovoked or cancer, usually more than 6 months, definite. So for cancer patients, we keep giving them until the cancer is cured.
In terms of, sorry, two questions. Number one, for DVT, did you ever started before you get confirmed pathological diagnosis?
For deep vein thrombosis, usually you can afford to wait. But let's say for ED, usually I will tell them that you just give them a dose of hexane while waiting for the ultrasound. Because in ED, they can't, let's say you come in overnight, let's say at 8 p.m. or 9 p.m., you can't get the scan. So usually what they do is that they'll give a dose of subQ hexane as well. And
Okay.
there's no harm because it's very safe.
In terms of choice of agents, so DOACs, warfarin, and the heparin groups of agents, how do you decide between the different agents?
So the APCP guidelines comes DOACs are now the first line for treatment of provoked. Let's just go under provoked venous thromboembolism, followed by subcutaneous then, and of course warfarin. So personally, for me, my practice has changed over the years. I'm now moving towards first line for all DOACs. Which DOAC? I would say is a point cost between rivaroxaban and apixaban. Dabigatran is not very favorable. We don't really use that. So under rivaroxaban, apixaban, which one do I use? I usually use rivaroxaban because it's once a day dosing, and that improves compliance.
Okay.
Any particular reason why dabigatran is not as favorable?
The problem is that the dabigatran trials, you need to overlap with low molecular heparin for 5 days.
Okay.
So that is logistically a bit more challenging.
So that was just based on the trial protocol, or were there issues when we gave dabigatran upfront without the Clexane?
That is fully based on trial protocol. So we have to follow what the trial say. So like you can also ask me the question, why does rivaroxaban need to be 15 milligrams twice a day for 3 weeks, then drop to 20 milligrams? It's basically based on trial protocol. And when I asked the primary investigator why and how did that come about, they say they pluck it out from the air.
Okay. Okay, got it. Are there special groups where DOACs are not the first line?
Patients with, let's say, renal impairment, I would not use it. Patients with massive PE, of course, you should not be using it.
And your cancer patients wise?
Cancer patients now, the evidence has moved. I would say any of my cancer patients who are able to tolerate orally, who currently does not have gastrointestinal or urothelial cancers, I would actually consider using DOACs upfront.
Oh, okay. Okay, thanks so much for that. In terms of, can we find out a bit about reversal? Because I understand some of the DOAC agents actually do have reversal agents, but do we hold them in our centers, and when do we consider reversal?
Okay, so there is also a guideline under the guides and policies on urgent reversal of anticoagulation. So if you ever face it, just pull out the guideline, it will teach you step by step what to do.
Okay.
So for reversal, for dabigatran, there is a specific reversal agent. It's called Praxibine. That one costs $3,000 to do it, but it's a very fast and efficient reversal agent. Reverses it within a minute, and it's full reversal.
Okay.
The other ones for apixaban and for rivaroxaban, the reversal agent is 4-factor PCC, or what we call octoplex, and that is also available as well. But it's not specific, but it does the job.
Okay. Is that the same as Indexinet, or that's different?
Adenexate, I think that's what you're trying to say. Adenexate is is definitely specific for it, but it costs 30,000 Singapore US dollars, sorry, for the reversal agent. So it will never come to Singapore.
Okay, got it. And the last question about anticoagulation. What about patients who have other events despite being anticoagulation? What do we do about it?
Then the always is about compliance.
Okay.
Compliance is the main issue. So what happens is that, especially on DOACs, you must be compliant because DOACs are so active. If you only take for 24 hours and you miss for 2-3 days, basically you're not protected for 2-3 days. So compliance is an issue. Patients on warfarin is also what we call time in therapeutic range for the INR. If a patient has a very poor time in therapeutic range, basically they are not really being anticoagulated. And these are usually the cause. But if the patient claims compliance and is very good, we want to consider increasing the dose, switching the agent.
Okay. And when we switch agents, do we switch between classes like DOAC, let's say vaccine, low molecular aspirin, or you can switch among
I think the experience in DOACs we haven't really seen. Either we're still using it or we don't, or the literature doesn't say much about it. Usually it's warfarin. What we do is that we increase the dose of warfarin. Let's say INR 2 to 3, we increase to 2.5 to 3.5.
Okay,
And same for low molecular heparin, we increase it by 20%.
got it. Okay. Is there any role at all for antiplatelet agents, let's say in patients with higher bleeding risk? Or
Okay, so for treatment of a VTE, for an acute treatment, there is definitely zero role.
okay,
For prophylaxis, there is a meta-analysis in patients who after knee operations or hip operations. Some of the surgeons put them on antiplatelet agent like aspirin. There has some evidence that it does prevent VTE rates. As for patients on long-term anticoagulation, let's say unprovoked VTE, and the patient has been on anticoagulation for 6 months and they want to reduce. Yes, there is some aspirin that was published in a paper in 2012, but it does not confer as much protection as when you're on full anticoagulation. So I'll say the role is very limited, but if the patient wishes to explore, they can talk to the haematologist and we can talk to them more.
got it.
Okay, then we have some subtypes of patients who don't get full-blown DVT, for example. We have patients who do a scan and we find that they actually have superficial vein thrombosis. And then there are also some patients with upper limb thrombosis. Could we just ask how do you manage such cases?
Okay, so the superficial vein thrombosis depends whether it is upper limb or lower limb. Upper limb, the evidence is very poor. We don't really know what to do with it. But the lower limb, there is some, there are two major publications on it, is that anybody with a superficial vein thrombosis that's more than 5 centimeters, we will treat. Or when it is very close to a deep vein, let's say the junction of where the superficial vein enters into the deep vein system within 5 centimeters, we will also treat the patient because you're worried it will start to progress and enter into the deep vein system. So length of it and position of it is important for the lower limb. The treatment-wise is very simple. It is prophylactic dose of Clexane. So you give 1 milligram per kilogram of Clexane once a day, and for 45 days.
45 days. Okay.
Yeah. For upper limbs, well, yeah, upper limb superficial vein thrombosis, usually I do not treat.
Okay. And upper limb deep vein thrombosis?
Yes, usually upper limb deep vein thrombosis you treat as for the same as a lower limb deep vein thrombosis. Okay. And usually upper limb thrombosis is associated mostly with a line. Let's say you have a PICC line, or you have internal jugular vein, or renal dialysis, you have a line there. And these are the usual ones that cause upper limb thrombosis.
So must you anticoagulate until they have the line removed?
Okay, so if the line is working, the recommendation is to keep the line in place. So don't pull out the line. If the line is working, okay, there's no point in doing that. So there's no need to. Yeah. Treatment-wise, we still treat them for 3 months, but let's say you have a PICC line and you can stay there for 6 months. Yeah. As long as the line is in place, anticoagulate the patient.
Got it. Okay. Is there any role for clearance scan?
The short answer, no.
What's the rationale for that?
Okay, so if you follow the life course, or so-called the natural progression of a clot, 30% of clots will disappear after 3 months. 30% will disappear after 1 year, and 1/3 of them will never disappear from the scans. They become a scar tissue. Okay. So it doesn't affect your management, since you know that more than 30% of let's say at 3 months, you have a 60% chance that you most probably still see a residual thrombus there.
Okay.
So then the next question, I guess we frequently come across as well, and it's kind of tied into that provoking factor topic. I think oftentimes we find that patients, despite our best history and physical examination, we can't really find any obvious provoking factor. So how often do you actually do a secondary prothrombotic workup, given the fact that I think some of us might have heard that it might not even change management because the patients would be on indefinite anticoagulation anyway. So could you shed some light on this?
This is a bit controversial on the workup. It depends on hematologist to hematologist. I am quite minimalistic. I would say do a very detailed clinical history, take history, make sure he has no red flags, meaning that we're looking for secondary cancers that could happen. So unprovoked DVT sometimes may be a precursor to a cancer that will come later. Because we do know that 10% of patients with unprovoked cancers will develop a cancer within 1 year. So there's a chance of that. So I would say age appropriate screening. So if a woman is 50 years old, do mammogram, make sure she has a pap smear done. For men, just make sure there's no loss of weight, no loss of appetite, and then just make sure he has no GI symptoms. That's about it for it. As for thrombophilia workup, I actually do not do at all for them because, as I said, it doesn't matter whether you are positive or negative, you are still committed to treating the patient lifelong for unprovoked DVT.
I see. But perhaps what about, let's say, things like antiphospholipid syndrome, where there might be other associations? Do you hunt for these things, or do you go by the clinical a bit more in terms of guiding?
Antiphospholipid syndrome is a bit difficult to diagnose because number one, you, as I said, you will start anticoagulation before you refer to a hematologist. So sometimes what happens once you start anticoagulation, you cannot send off the lupus anticoagulant. It's not going to be accurate. It'll be falsely positive. Of course, you can send off the anti-beta-2 glycoprotein and the anticardiolipin because these are not affected by the anticoagulation. So there are times I do send them off, but you're not sending off the full panel. So let's say, for example, you know that this guy has a PE. Before you start anticoagulation, you send off the lupus anticoagulant, and that will be helpful. Yeah, it does have some effect management because patients with antiphospholipid syndrome, DOACs has been shown to be inferior or not very helpful in preventing recurrence. So in these particular patients, you may wish to consider warfarin for them instead of DOACs.
Okay. Just a quick word on IVC filters. Who do we consider them for, and how long can it last for? And let's say the bleeding risk is removed. We then take out the IVC filter, put on anticoagulation. How do we navigate this space?
So I think the take-home message for IVC filter is do not insert one. And if you insert one, take it out. All right. So I would say I very rarely insert IVC filters because there is risk involved. You know, you're puncturing into a vein after all, and there's a risk that you're not able to remove the filter. There's a 5% risk that the filter cannot be removed and becomes permanent filter in it. So I would say that all IVC filters inserted in NUH are removable, and you should try to remove them after once the indication is not needed. So let's say once the bleeding risk is removed, you can anticoagulate the patient, just pull out the IVC filter.
Okay. And the reason why you say generally not to insert is because its efficacy also isn't that good, or it's more...
Okay, the evidence for IVC filter is controversial, meaning that have they ever had a trial in which you say one group of patients you don't anticoagulate, the other group of patients you anticoagulate. The not anticoagulated group you put in IVC filter. No, that was never done. So the IVC filter comes from a trial in which both groups are anticoagulated and one group inserted the IVC filter, and both groups are completely anticoagulated. And they show to reduce by 20 to 30% chance of PE in the group with the IVC filter. And it only is effective for 2 weeks. After 2 weeks, it tends to be the filter.
I see. Okay, so this is one of the last questions. I guess a bit more of an interesting question to ask. What's your thoughts on VT in COVID? And I've been seeing quite variable practice, lots of articles going around. So what's up with it?
So there is a few consensus statements that is out on VTE in COVID. If you're looking at it from the publication so far, we're looking between 20 to even 60% incidence of VTE in COVID patients. But bearing in mind that these preliminary studies, the observational studies, and they are mainly generated from the Caucasian population, although the Chinese publish the data. So I say that the jury is still out there. I do not want to comment more because it's very controversial.
Thanks a lot. Okay, in terms of the last question, do you have any take-home messages for really the residents, what to pay attention to, what to look out for, and what pitfalls are there when it comes to VTE?
I think for VTE is that if you're working in A&E, always have a high index of suspicion, whether the patient has VTE or not, and then use the well scoring to help you with it. And as for inpatient, do not use the scoring system because it doesn't work, and just scan the patient for it. And when in doubt, and the patient has no bleeding risk, start anticoagulation as soon as you can, even without the scan. I think that's the most important message.
Okay, thanks so much, Dr. Yap. Edwin, do you have any other last questions for us?
No, I think we've had a pretty comprehensive session. Thanks, Dr. Yap.
Okay, thank you guys.
Okay, thanks so much, Dr. Yap.